Good afternoon. Thank you. As mentioned, the focus of my talk today is going to be on how we reimbursed hospitals versus how we reimburse physician practices. A couple of notes on that. First and foremost, Avalere Health, in case you don't know who we are a policy advisory firm based here in DC. One of the really fun things about working at Avalere is we work with everyone. So I have life science customers, I have hospital customers, I have physician customers, I have government customers. I get to work with everybody. And as a result, I sit in the middle a lot of times, and I get to see kind of the different incentives and how they interact. And so one of the roles we try to play is to be as objective as possible, to try to understand what the different incentives are driving people to do and what that means for everyone. What it also means is if you hear me express an opinion today, and I do have opinions, they are mine and they're not my firm's, so please don't call my boss. The other thing to focus on is we're going to focus on kind of that medical benefit again. So Dr. Newcomer talked about the medical versus the pharmacy benefit. Most of the studies that we've looked at here really are on the medical benefit, how we're paying hospitals, how we're paying physicians for the drugs and the services that they provide. We're also largely going to focus on the non-Medicare population. And I know we talk about Medicare is a large portion of this population, can be 50 or more percent. From the terms of our pricing strategy, from how we pay providers, drugs are largely paid the same. It's ASP plus 6, as we've talked about a lot. So as we see differences in costs, as we see differences like that, it's really driven more by utilization, which can have a lot of other influences. As we look at the commercial space, there's two things to keep in mind. One is that utilization can obviously still be different, but there's a lot of other pricing power that goes on within that space. And what we're going to look at is kind of the results of some of those analyses. And secondly, one of the big things I always have to remember is that while Medicare is a large portion of anyone's practice, you're probably making most of your profits from your commercial patients. In the most extreme, I like to talk about the dialysis industry. I do a lot of work with those folks. Their patient mix is about 90% Medicare. All of their profits come from the other 10%. And in fact, it's a little bit less than that. So when we talk about kind of the incentives driving the market, it's really useful to look at that commercial space to understand why some things are starting to happen. So what's going on? We've heard this a number of times today. Outpatient chemo is shifting to the hospital. Over the last couple of years, we've seen it shifting away from the office-based. Now, part of it is due to the hospitals purchasing the physicians. We can talk about what's driving that trend, but we know that that's what's going on. Part of it's driven by the hospitals trying to get bigger. There's a lot of efforts out there right now to say we need to have more comprehensive, coordinated care. If you look at a lot of things in the Affordable Care Act, if you look at a lot of the bundling models that are coming out, it's really encouraging people to try to be coordinated. Well, one of the ways you coordinate is you purchase everyone in your local market. As a number of authors have written, be careful what you wish for. Part of the trend, obviously, is also about the increasing cost of chemotherapy drugs. And what I mean by that is, I think what a number of the speakers have talked about is not necessarily the kind of the reaction to the cost of the drugs, but the capital you need to purchase these drugs and to stay afloat. There's a lot of physician offices out there that I talk to that can't afford a lot of the drugs they need. So one of the things they do is they look for a hospital partner. This trend has pretty significant implications, as we've been talking about all day. Medicare obviously pays the same regardless of the setting. It does start to make a difference about what the patient's copay is, especially on the Medicare side. But when we start to look at that private payer market, that's where it really starts to get interesting, because there is a growing body of evidence that really shows what that payment difference is and really raises some questions about, is this the right incentive that we want inside the market? We've talked a lot about the patient focus, and I'll talk about it quite a bit as well. It gets complicated when you talk about on the commercial side, because most commercial benefit plans, when you're looking at the medical benefit, are more about in-network and out-of-network and less about kind of the value of the drug, the value of the service that's being purchased. So a lot of insurers look to try to put people into an in-network provider that theoretically they're paying a little bit less to, but it's not necessarily about encouraging use of one drug versus another drug. The other big thing to think about, and my colleagues and I at Avalere, when we look at these new payment models coming out, we have to remind ourselves, whatever we build in the future will be based on what we do today. And so if there are discrepancies or disparities in today's market, we're only going to continue them unless we really understand what those disparities are and we address them inside the new models. All right, so pretty much the only Medicare data I'm going to show today is this one, and this is obviously something we've been talking about throughout the day. But this is a study that Moran did for, I believe it was COA a couple of years ago. that showed kind of the increasing percentage of drug spend that's headed over to the hospitals. The reason I like to use this one to talk about the trend is, again, drugs are paid the same in both settings at this point. So as we look at the Medicare side, we can make a statement about the number of patients just simply by looking at kind of the share of the drugs that are flowing through both sides. We know this trend has continued. Obviously, this stopped in 2011, especially over the last couple of years. Dr. Connie showed some of the anecdotal evidence. We've seen some of it ourselves. The hospitals have been focusing on oncologists, on some of the other infusion drugs. They have recognized there is a real profit incentive with some of these drugs. And again, I don't want to imply that that's the entire reason they're doing it. A lot of these hospitals are also looking for ways to coordinate care. And if they can bring the physicians in-house, that's one of the ways you can start to think about that. Right, I'm going to spend a little bit talking about a study that we did for COA a couple of years ago. And Dr. Gould, you stole some of my thunder earlier by talking about this. But I'll dive into a little bit more. So we took a look at 4 commercial health plans and a wide range of patients, and I'll show you some of the demographics here in a second. But we took a look and divided the patients up into folks who received their care primarily in an office versus primarily in a hospital. We find primarily as 60%. There's debates about, do you say 100%, do you say 50+%? We found that there wasn't a big difference once we got to about 60%. There were some patients who were bouncing back and forth. But by and large, if you were going to an office, you were going to an office. We also then looked at it from initiation of therapy by month. And I thought this was a real critical piece in what we did, is because we wanted to look at, obviously, episodes last different lengths. And one of the things we didn't want to confound was trying to look at different lengths of episodes and making statements about the total cost of care provided during those episodes. So the data that I'll show you on the output really looks at it on a per patient per month basis. And as a patient exited, as they stopped therapy, as they died, whatever you want to call it, they did exit our analysis. So we're looking at patients who continued therapy by month. We created episodes. We required a number of variables inside of there. So if a patient was absent from therapy for at least 60 days, we moved them onto a new episode. One of the keys, and this is one of the parts of our study that really didn't get noticed and was one of the reasons I think that I was asked here today to talk about this, we had to use a variety of methods to find our patients. Now, you wouldn't think that that is a weird statement to make. But when we started this, and I'm largely a Medicare analyst, I work a lot with Medicare data. So the first thing I said is, okay, well, all of these drugs have J codes. I'm going to go and look for any J code for chemotherapy. And we went through the first time, and I didn't find anybody, or found very few people in the hospital. And it blew me away. I kind of went, why did I not find anyone? And in one of our calls with our technical expert panel, they said, well, did you look for revenue codes? And I'll talk a little bit about what the implications of that are, but we found a lot more patients when we went back and looked for revenue codes. And that has pretty big implications when we talk about all these issues going forward. And then we did test for a couple of factors. We looked at the type of cancer, we looked at the kind of prior history of cancer, and we looked at patient age and gender. And for all of you oncologists in the room, you're immediately looking at me and going, but you didn't test for stage. And my reply to you is, I would love to test for stage, but for as bad as the data is, we don't have anything on stage in any of the data that we get. United Health has probably the best data set on this, and they've done some really interesting work on this. The rest of us are shooting blind. The best thing we can do is look at prior history of cancer to try to get a sense, is this a patient who's got a recurrence, or is this a patient who's got new therapy? Obviously, as you look at a plan database, if someone is new to the plan and they had cancer 5 years ago, we don't know. So we have to make a lot of guesses about what we're really looking at the end of the day. All right, so a couple things on the patients, just to get a sense of what we're looking at. Again, these were 4 commercial plans. There were some Medicare Advantage plans inside of there, so we do have an older patient population. But when we're talking about a cancer population, pretty representative at the end of the day. I had a nice sampling of cancers as well, so when we were looking at our output, felt pretty comfortable. We were looking at a good representative sample of what was going on out there. This one really interests me. When we talk about what patients want, this I found interesting. As patients get older, they tend to use the office more. Now, there's 2 ways to say that. There's one that says, as patients get older, they care for the office more often, more commonly, or there's another way to say it, that the younger patients may have more complex conditions and require the resources of the hospital. Again, looking at claims data, we can't answer that, but it is a very fascinating output that shows as the patients got older, we tended to see them in the office much more often than we saw them in the hospital outpatient department. By cancer, obviously this now plays into a role in the prior slide as well, but if we look at something like prostate, almost 90% of our patients were receiving their care almost exclusively or majority out in that office setting. As we moved into some of the more complex cancers, we saw the hospital become a much more common place of care. All right, so our overall results, and again, what you're seeing here is across the bottom is the month of therapy. So that 1 is the first month, 2 is the second month. It's for patients who are continuing therapy over time. This is an adjusted calculation. Again, it's adjusted solely for age, gender, and prior history of cancer. And what we found is kind of on an adjusted basis, on a non-mix adjusted basis. So most, again, if you're an economist in the room, you're saying yes, but you're combining all those prostate cases with breast cases, and we'll talk about that in a second. But overall, we look at the data, office-based is lower on a total payments to the providers compared to the hospital-based. And again, from a payment perspective, what we're talking about is what the plan paid the provider, paid all providers for patients who are in their first or second or third or fourth month of therapy. It's interesting when we look at it by cancer. So now we see on a prostate perspective, on lung cancer, the GI or the breast, same basic story that we see over time. So now we start to be able to say, okay, at least now we're controlling for the type of cancer. We're looking at relatively similar regimens over time. Obviously, there can be all sorts of confounders in there, but if we look at just the data as it starts to come out, it looks like the office is getting paid less on average than a patient who's treated in the hospital for the same type of cancer. So one of the things we couldn't do was take a look at the exact regimen received. And I'm going to come back to that in a little bit. And it was largely because of that issue I talked about with revenue codes. We couldn't look and say for sure what type of drug the patient was receiving because a revenue code doesn't give us that clarity. Milliman followed up our study a couple months later with what I think is a very, very well done study. And they looked at a couple of key cancers. And again, we've seen these numbers a little bit today, so I won't bear a lot on this. But I think there's two interesting things on this slide. One is the overall results are the same. We're seeing lower costs for patients who are being seen in a hospital setting, or excuse me, an office setting relative to a hospital setting. Milliman also started to break it up between the overall cost of the episode, which is what you see in that middle columns there, versus the session cost. And what they defined as session was anything received the day the patient got chemotherapy. So if you went into the office and maybe they ordered lab tests or maybe they did a scan, all that shows up during a session, but we're not getting all of the other things. What I always find interesting is to look at the differences between these numbers. And if you go down the list pretty consistently, is the differences between the numbers on the far right, the average allowed cost per session, is about the same as the difference between the numbers in the middle, which says to me that the differences in the total spend for cancer patients is being driven by the variability in the drug costs, not by all of the other things that are going on. What happens the day of the chemotherapy is what's causing this, not additional hospitalizations, not additional care that's required. It's really largely being driven by the cost that's being paid to the office or to the hospital the day those sessions are provided. Now, the problem I had with this particular approach was when you look at this, it comes back to a statement I made earlier. We don't know the length of these episodes. We don't know if the reason the hospitals had total costs that were higher on average was because maybe their patients were in therapy for 9 months, whereas the office was based on 8 months. I can tell you from our study, what we found was patients receiving care in an office setting tended to have longer episodes. So that would somewhat contradict the statement I just made, but unfortunately we can't entirely tell by looking at this number. But what Milliman did do was look at it on a drug-by-drug basis, and this to me is the most interesting output that I'd seen. So this is the exact same drug, exact same dose, looking at what the payers paid to a hospital versus what the payers paid to an office. And down the line, the costs are higher. We're now starting to see kind of some of the evidence of what's going on in this marketplace. And of course, you're going to say to me, well, of course, hospitals have more market power. Hospitals have the ability to command higher prices. That may all be true, and hospitals may have overhead, but are we explicitly making this decision, or are we allowing those things to drive fundamentally different prices in our marketplace? And what gets really interesting to me is now we're talking about the commercial marketplace. We're talking about all of this being financed by premiums. As we talk about the consumer out there, the consumer's focused on premiums. All of this starts to drive our premiums. As more patients start to shift to the hospitals to these higher costs, all of our premiums go up. So even if you're not on therapy right now, you're paying for this at the moment as this trend continues to happen. An IMS analysis that just came out within the last about month or so found basically the same issue. So again, same drug, same dose. Inside of their database, what you have here on the red bars, and I apologize, this one didn't copy too well, but the red bars is that hospital outpatient per dose, and on the physician side in the blue, and again, it's that same 2 to almost 4 times difference in pricing. we're really starting to build the evidence that what is going on in our pricing scheme out there, not the cost of the drug, because again, remember, this is the same drug, same dose. So in theory, if everyone could buy it at the same price, we're starting to see a substantial difference in reimbursement, which is obviously driving our premiums, which is driving a lot of the conversation we're having here today. Do we want to pay for this? And if so, let's make the decision to actually pay for it. And of course, again, as we get into this afternoon session and start talking about new models coming out, we need to make sure the system is built on a stable platform. All right, so I want to come back to the concept that I talked a minute ago about revenue codes. So again, in our study, when we went in and looked, we found a substantial portion, you see the numbers down there at the bottom, about 34% of our hospital outpatient episodes, we only identified via a revenue code. And you're saying to me, so what? HCPCS codes aren't that granular. They don't tell us a lot what's going on. The revenue code that we used largely was 0331. That's literally administration of chemotherapy. I have no idea what's going on that claim other than the patient got chemotherapy administration. I know they're a prostate cancer patient, maybe they're a breast cancer patient. I don't know what drug they got. I don't know what dose they got. So when I started to look at my study, I could make no statement about what was the underlying cause of that driver. Now, there's a really interesting, and this is, we're going to get really wonky, and I apologize for this. Physicians use a form called a CMS 1500 to get paid. Hospitals use a form called a UB04. Don't ask me why we use different forms, we do. Hospitals are required to submit a revenue code. They are not required to submit a HCPCS code. On the physician side, they are required to submit a HCPCS code. It makes a big difference in terms of what we start to watch. Medicare realized this a while ago and said, okay, everybody's got to use that J code. I got to know what's going on. And oh yeah, by the way, I'm paying the same no matter what. So tell me what drug you use, tell me what J code you used, and I'll pay you accordingly. A lot of commercial payers don't do that. We see a lot of evidence from the market that commercial payers are using what's called a percent of charge basis, which simply means if I'm a hospital, I tell you what my charge is for the product that I just provided, you're going to pay me 60%. I know one of the large blues out there, that's their policy. Somewhere between 50 and 70%, depending on your market power, depending on what negotiation I've done with you that particular year. On the physician side, it's much less common to see a percent of charge. It's much more often to see some sort of a fee schedule coming through. So to take a look at that, we said, well, let's take a look and see, are they charging different? Because that would start to explain a lot of this difference. So we took a look at the Medicare data. This is something that we've done both on the hospital and on the physician office side. We looked at the same drug, same dose. So this is something we could actually look at. We pulled out just a sampling of drugs. And what we found was, not surprisingly, hospitals are marking up their drugs significantly more than physicians are. So same drug, same dose, we're seeing anywhere between a 1 and maybe a 3-time markup from the physicians. We're seeing anywhere between a 3 and a 5-time markup from the hospitals. Again, same drug, same dose. The hospitals very rightly reply that there are overhead that they have to handle. There are other costs that they have to handle. Don't dispute that, don't deny that, but again, are we explicitly paying for those costs, or are we allowing those costs to be passed through to us via our commercial premiums, all of which now is being exacerbated because more and more physicians are moving to the hospital and more of our care is moving into that hospital, getting paid at these payment rates. And again, how do we set up a new system if this is the trend that's going on underneath it? All right, patient out of pocket. There's been a lot of talk about that today, and I have a slightly different take on this. Again, this is the data that IMS just put out. Again, what we see in the commercial marketplace is out-of-pocket, especially on the medical benefit side, is more often driven by network design and not driven by the drug you choose or the product you decide to use. So IMS put out, they said it was $138 on average across all therapies, but look at the individual therapies. In particular, look at that top one right there. $6,200 difference for the patient who goes to the hospital versus the office, what the payer paid. Patient actually paid less to go to the hospital. So not an incentive for the patient to go where the cost is cheaper. In fact, they had a lower copay. And what I would suggest is the patient is not even thinking about that as they're going place to place. Now, this is not talking about any of the other conversations we've had about kind of that $50 threshold, the lower adherence over time. What we are talking about here is it's not consistent and it's not uniform and it's not driving a lot of payer policy at the moment. Network design is driving much more than that. There's also a lot of complicating factors when we start talking about patient out of pocket. In the Medicare space, I'll come back to that piece for a minute, all those fee-for-service patients, majority of them have Medigap. Most of them aren't exposed to this. I'll use the anecdote. People who know me know I love to talk in anecdotes. My father was diagnosed with Hodgkin's a number of years ago. He's doing fine. When he was diagnosed, he was 67 years old, but had not signed up for Medicare yet. Lives in Illinois. Blue Cross of Illinois is a great insurance plan. People really love it. My mom was still working, so he was getting his insurance over there. Physicians in Illinois love Blue Cross of Illinois. They are a really good payer. They pay really high rates and they pay really fast. So when my doctor got diagnosed, both his normal primary care doctor and the medical oncologist he started to see said to him, oh, you don't want to change insurers. No, Medicare's not any good. You want to stay on Blue Cross. My dad called me up after about a month therapy. He hadn't gone on drug therapy yet. He was still going through all his tests. And he said, Eric, my out-of-pocket is already $600, and I've only been doing this for a month. I said, okay, Dad, pull out your EOBs, start showing me the codes. I walked him down the list. I showed him exactly what Medicare would have paid. Medicare would have paid about half as much as Aetna was paying, or excuse me, that Blue Cross of Illinois was paying. And then I said, oh, no, by the way, now your out-of-pocket would have been 20% of that. But, oh, yeah, by the way, we're going to buy you a Medigap plan because you're allowed to. So guess what? Your out-of-pocket's nothing. My dad goes, okay, I'll go down and sign up for Medicare tomorrow. What that also did was it made him insensitive to the cost of his therapy. He proceeded to go on a very high-cost chemotherapy for the next 2 years. Don't ask me why anyone goes on chemotherapy for 2 years. We can have a long discussion about that, and I'll tell you exactly what I think. But he was on a very long dose. He didn't even think about it. And in fact, he kept saying to his medical oncologist, what's going on here? And the oncologist said, well, as long as Medicare keeps paying, we'll just keep doing it. My reply to him was, when does Medicare stop paying? Like, what doctor, what do you know that I don't? And I work in this area. So starts to say on the Medicare side, that's the problem we have when we look at patient out-of-pockets. Obviously, when we talk on the commercial side, we've got other issues. We've got caps that we have to think about. We've got all these sorts of benefit designs that we've got to think about. All of these complicate the issue when we start talking about patients and what they want versus how we're paying for people. I tend to say, let's focus on how we're paying people and let's have the patients be as immune to this as they should be. They're going through cancer care. So just kind of wrapping it all up, my thoughts as I come out of this, the costs are ranging on a variety of factors. I don't want to downplay the acuity factor. We can't prove and we can't make any statement. In fact, I will be willing to say that patients who go to the hospital probably are a little bit sicker. They probably require additional care. What we can say is when we look at the cost that the payer is making to either the hospital or the physician office, there's a big difference there. And how you structure that and how you set that up makes a big difference. And it will play a big role as we start talking this afternoon about new payment models. It gets very difficult to set up a new payment model if we've got this underlying trend going on. And again, finally, on the patient side, there's probably less of a role simply because a lot of patients are immune to these costs. We're not incenting them necessarily to choose a lower cost therapy. Again, in my opinion, we should not necessarily be forcing them or encouraging them to choose a lesser cost therapy. We should be encouraging them to receive as much care, appropriate care as we can, and put the burden on the physicians and the providers and all of us in the policy space to be doing that. Thank you.
Our final speaker before we let you at the panel is Dr. Kolodje from Aetna. His is the only title that doesn't have a versus in it, so I decided we needed to come up with one. So he's going to speak on broad coverage versus out-of-pocket costs.